Without much ado, we welcome you all to this session. And we will get on with starting with the first talk and the first session, which mainly is on advanced heart failure. Thank you.
Thank you. Thank you so much, sir, for the welcome note. Now, for the first session, which is on advanced heart failure. May I please request our chairpersons, Honorable Dr. Munna Das and Honorable Dr. Lalit Kapoor, to please come up on the stage. Now, may I please request our Honorable chairpersons to introduce our speakers.
Good morning, everybody. Our morning session discussions are on 4 topics, as we know. We will have our chairpersons on board accordingly as they come. We have our first speaker on advanced heart failure management. What do the guidelines say? And nothing other than Dr. Aditi Singhvi. So she is a prolific speaker, and we are very eager to hear from her. The main thing in advanced heart failure, as we know, is that we first need to define advanced heart failure, and there are obviously the ESC-based guidelines published in 2022, and based on that, and also our the clinical scenario, which dictates advanced heart failure, guideline-directed medical therapy should be the prime objective. Beyond that, we have other therapies, your device therapies and others, and those patients who are actually not destined to have any of these or not even a candidate for heart transplant, then we have certain other palliative therapies. So to sum up and I will ask Dr. Aditi to just take over from here. Thank you.
The presentation. Good morning, everyone.
Sir, please come.
Good morning, everyone. So as you may have noticed from the agenda, there's a very nice flow of topics from advanced heart failure, defining it, management, to selecting patients for heart transplant and their subsequent management. So I have been given the task of discussing management in advanced heart failure. So my first disclosure is the guidelines in this per se are quite limited. A lot of it is expert opinion. So some of the things that I will be talking about are more related to expert opinion, as well as some literature that exists in this space. As we know that most of the trials that have been done are for stage C heart failure patients, and there is very little evidence-based data about medical therapy, procedural therapy, surgical therapy, etc. in advanced heart failure per se, outside of durable LVAD and heart transplantation. So with that, I'll start. It's not projecting here. Okay. So first we need to know what the definition is. I'm sure for the audience here, this will be a bit of a revision. We are all familiar with the trajectory of heart failure patients. There is a period of stability, and then about 1 to 5% of patients with heart failure will progress to this downward stage despite our best efforts, where they have a waxing and waning course, but an overall downward trajectory. And this is what is defined as advanced heart failure or refractory heart failure. This is when our traditional care, including disease-modifying therapies, they stop working, or our patients are not tolerant to these therapies, and we have to change our focus in these patients from considering their goals, whether they want to be aggressive and pursue advanced therapies or they want to take a palliative approach. So we'll be talking about this phase of heart failure, which is advanced heart failure or refractory heart failure. So the definition includes a number of conditions, and it is more of a clinical syndrome and a situation as opposed to just a clear-cut objective definition. So the first couple of things to note are that these criteria must be present despite optimal guideline-directed treatment. So severe and persistent symptoms of heart failure, severe cardiac dysfunction, which is defined as an EF of less than 30%, but important to note that it can occur even with a higher ejection fraction or even with a normal ejection fraction. There can be isolated RV failure, severe valve abnormalities, severe congenital heart disease. Repeated hospitalizations for either congestion, low output state, or malignant ventricular arrhythmias, and severe impairment of exercise capacity. And we have to make sure that these limitations are not as a result of non-cardiac conditions such as severe pulmonary disease, cirrhosis, or renal disease. So how do we identify and prognosticate advanced heart failure? Because that is going to determine our management. So I need help is a useful mnemonic to remember how to identify patients who have advanced heart failure. As you saw that there are various conditions that can be present. They don't need to have all of them, but at least some combination of these are usually present in patients. So I need help is a good mnemonic to remember. I standing for inotropes, previous or ongoing requirement for inotropes. N for NYHA class, that is persistent NYHA class 3 or 4 or persistently high natriuretic peptides. E for end organ dysfunction like worsening renal function, worsening liver dysfunction, or cardiac cachexia. E for very low ejection fraction, but again, as we discussed, ejection fraction is not the only criteria to define advanced heart failure. These other clinical signs and symptoms should also be present. Repeated defibrillator shocks. H for hospitalizations. E for edema and escalating diuretics. L for low blood pressure necessitating reduction in medications. P for prognostic medications, so inability to titrate the medications or having to actually stop the medications as well. Now, this prognostic stratification of patients is essential to identify the ideal time for referring patients for advanced heart failure therapies. We can discuss expectations to patients and families and help plan treatment and follow-up strategies. Advanced heart failure recognition and management is important because these patients have a very poor survival. So these are data from various trials, Optime trial, Intrepid trial, which showed that patients who require inotrope have less than a 10% survival rate at 1 year. And even patients who are Intermax 4, 5, 6, 7, they have a poor survival. So these are non-inotrope dependent ambulatory sort of stage 4 heart failure patients, but even in them survival is poor. So with Intermax 4 also survival is only about 40% at 1 year, survival free of VAD rescue is 40% at 1 year. Intermax 5 and 6 are slightly better, around 70%, but still not upwards of 90% like for stage C heart failure patients. Now, in ambulatory heart failure patients, sometimes it can be difficult to identify who is progressing towards advanced heart failure. And in that category of patients, exercise testing can be helpful for further risk prognostication. So, cardiopulmonary exercise testing is reproducible, provides objective data about cardiovascular reserve and prognosis. For a maximal test, the respiratory exchange ratio should be more than 1.05. Patients should achieve their anaerobic threshold. And ideally, we should do it once patients are on maximal guideline-directed medical therapy. A cutoff of peak VO2 of less than 12 ml per kilogram per minute or less than 14 is recommended if patients are beta blocker intolerant to guide heart transplant listing. And this data is from seminal work by Dr. Mancini and her colleagues in the 90s, which showed that if your peak VO2 is less than 10, then you have a very poor survival. So that is where the cutoff of 12 and 14 have been derived. In women and patients less than 50 years, a peak VO2 of 50% less than predicted for their age and sex can also be used. And in obese patients, the peak VO2 should be adjusted for their lean body mass. VEVCO2, that is the ventilatory equivalent for CO2, a slope of more than 35 also has a poor prognosis and can be used to guide heart transplant listing. If you don't have the capability of performing an exercise test, then 6-minute walk test can also be done, and that is easy to perform. There are various risk scores also that can be helpful in ambulatory patients, like the heart failure survival score, as well as the Seattle heart failure model. Both of these are free and online and available online. These utilize commonly So both of these scores, there are various other scores also, but these are sort of the ones that have the best validation externally as well. They utilize commonly available clinical signs and symptoms, and they can give you the patient's expected survival, and that can be used to guide heart transplant listing as well. It is recommended by the ISHLT guidelines to not use these risk scores in isolation, but as helpful in addition to other clinical signs and symptoms and the clinical picture. Now, goals of management in patients with advanced heart failure. First and foremost, we want to control symptoms, improve quality of life. We want to reduce hospitalizations. Each heart failure hospitalization increases the risk of mortality by 30% in the coming 3 months. And we want to establish the patient's wishes as well. Points to consider in decision-making in advanced heart failure patients. We need to determine that the symptoms are not due to a non-cardiac disorder. Important that sometimes patients can be severely symptomatic and appear to be very advanced with a new diagnosis of heart failure, but often these patients who have a new diagnosis can improve substantially if they are stabilized initially. Evaluate for non-adherence to medications because that can be the reason for their advanced signs and symptoms. We need to carefully review their medicines to make sure that all therapies have been considered. And most important, we need to discuss prognosis with patient and caregivers, discuss patients' values, goals, and their preferences, how aggressive or not they want to be. And we need to have discussion with the multidisciplinary team to make sure the patient has adequate information to make an informed decision. So what are our options for managing patients who have advanced heart failure? We need to establish advanced care directives, that is, establish the patient's goals of care, heart transplant, temporary or durable mechanical support, chronic inotropes, experimental surgery or drugs, and ultimately palliative care or hospice. So I'll quickly review some of these options, starting with non-pharmacological therapies. So fluid and sodium restriction is often recommended to these patients. Hyponatremia and diuretic refractory congestion is common in this population, but the evidence of fluid restriction and sodium restriction is of very low quality, and they have not been shown to have any benefit on clinical outcomes or even any impact on diuretic use. Moreover, patients with advanced heart failure have a high risk of cachexia and malnutrition, so any dietary restrictions and recommendations should be evidence-based and comprehensive. Often in our forward to overly restrict sodium, we end up limiting patients' diet so much that they become even more malnourished than they already are. So we need to be careful about this. Next, coming to pharmacological therapies. These patients tend to have significant congestion, repeated congestion. We think we'll give them diuretics, we'll diurese them, and then they'll live forever, right? But that's not the case in this population at least. Kidney dysfunction is common, loop diuretic resistance is also common, which is a whole topic in and of itself. There are various reasons for it. We tend to keep increasing doses of loop diuretics. The renal tubular threshold in these patients is shifted to the right, so you'll need like more than a pound of Lasix to get the same response to diuresis that you would get from, say, 20 milligrams in a normal person. Diuretics, higher doses also increase RAS stimulation, so that further increases sodium reabsorption, fluid reabsorption, and contributes to so-called diuretic resistance. Metolazone is commonly added when patients are not responding to loop diuretics alone, but important to note that metolazone is associated with increased mortality. Now that can also be because this is a sick population, but even after controlling for these confounding variables, it has been shown that metolazone actually increases the mortality, probably related to increased neurohormonal stimulation, hyponatremia, and other side effects of metolazone. If there is significant failure to respond to diuretics, ultrafiltration can be considered. And for symptomatic hyponatremia and volume overload, tolvaptan can be considered. Now coming to our so-called goal-directed medical therapy in this population. Now I'm talking about advanced heart failure patients only, not about stage C heart failure patients, which is where all the goal-directed medical therapy evidence is from. So generally, this population is intolerant to medical therapy. trials for ACE inhibitors, ARB, beta blocker, SGLT2 inhibitor, MRA, hydralazine isosorbide dinitrate, ivabradine. They did not include patients with advanced heart failure or had a very small number of NYHA class 4 patients. So we cannot extrapolate the mortality and morbidity benefit seen in stage C patients to stage D patients. LIFE trial was one of the few trials conducted only in advanced heart failure patients. This was a randomized trial of sacubitril valsartan versus valsartan in patients who had advanced heart failure. They had high NT-proBNP, use of inotropes, hospitalization, so various markers of advanced heart failure. And as we can see here, this did not improve reduction in NT-proBNP, and it did not improve heart failure hospitalization rate in this population. So there is no evidence to support use of ARNI in patients with advanced heart failure.
Just wrap up because
Okay. So again, the other heart failure medications, there may be some role in select patients. For instance, digoxin may be considered in symptomatic patients. Ivabradine can be considered if patients are intolerant to beta blocker. And in patients who have significant renal dysfunction, hydralazine isosorbide dinitrate may be useful as well. 𝐸𝐴𝐺𝑤𝑎𝑡 was studied in a slightly sicker population compared to the usual stage C patients. However, even 𝐸𝐴𝐺𝑤𝑎T did not have any improvement with an NT-proBNP.
Apologies for the inconvenience, ma'am. I would request you to please wrap up in next 30 seconds.
So inotropes can be seen, but despite improving hemodynamics, they have not been shown to have any improvement in the patient's outcomes as well. Then other comorbidities should be addressed. IV ferric carboxymilate should be used in iron deficient patient. Obstructive sleep apnea should be treated. CRT does not have any benefit once there is severe MR or the LV-EDD is more than 75 millimeters. CardioMEMS is a device that can be helpful in advanced stage patients with NYHA class 3 symptoms. And cardiac contractility modulation is also a device that is available but has been shown to have minimal benefit. Okay. Then for secondary MR, which is frequently present in patients who have advanced heart failure, mitral annuloplasty has not been shown to have any benefit. Mitral clip is quite controversial in this patient.
With all my sincere apologies, ma'am, may I please request you to wind up in next 30 seconds.
Thank you so much.
Sure, ma'am, please.
Sorry, there was a lot of confusion, I think, earlier on when I was presenting as well, so it was difficult to present. Okay. Now, secondary MR is frequently seen in this population. And there is a concept of proportionate versus disproportionate secondary mitral regurgitation. And as we know, the mitral FR trial had patients that had bigger end diastolic volume and more severe, more sick patients. In that population, mitral clip probably does not have any benefit, but like the 𝐀𝐝 trial showed, there might be a benefit in patients who have disproportionately severe MR. Coronary revascularization is also controversial in patients who have advanced heart failure. Based on the STITCH trial, there may be a benefit from surgical revascularization in select patients, but PCI has not been shown to have any benefit. Interestingly, the 𝐀𝐝𝐢𝐭𝐢 heart transplant trial, which was published this year, showed a significant benefit with atrial fibrillation ablation in patients who had advanced heart failure. So that may be something to consider as well. Important to know that antiarrhythmics have never been shown to have any benefit, and so this might suggest that the side effects from antiarrhythmics may actually outweigh the benefits of rhythm control. Lastly, mechanical support and heart transplantation, which are the only life-prolonging therapies in patients with advanced heart failure. I won't go into details of how the patients are selected, but just broadly mentioning temporary MCS can be used as a bridge to decision or recovery or to LVAD and heart transplant. Durable LVAD is definitive therapy, improves functional capacity and survival, and even INTERMACS 4 patients may experience improved survival, but not INTERMACS 5 to 7 patients. Then heart transplant also offers benefit to patients with stage D heart failure. There are efforts to minimize waitlist mortality. Patient selection should be based on thorough evaluation, patient education. You need to evaluate their comorbidities, caretaker status, goals of care, use a multidisciplinary team. Right heart cath is a must in transplant evaluation, and it should be repeated. Vasodilator challenge should be used if the PA pressures are high as well. And if acute testing is unsuccessful, then PVR should be reassessed. Lastly, palliative care for patients who are not candidates for advanced heart failure therapies should be used. So to conclude, early identification of patients with advanced heart failure is needed. We should reevaluate heart failure patients for whether they are progressing to advanced stage every 3 to 6 months. We need to ensure optimization of GDMT, consider adjunctive medications, procedures, and devices as discussed, and very important to timely refer patients for LVAD and transplant. For Intermax 1 to 3 patients, consider temporary MCS as bridge to LVAD and transplant. For Intermax 4 or more, greater patients, assess them closely, assess their risk scores, do cardiopulmonary exercise test, and they require very close follow-up. Thank you. Sorry for the delay.
Thank you, Ms.